Manipulation and exercise for low back pain in adolescents. What do we know about low back pain in adolescents? We know that adolescent low back pain has been shown to be a strong predictor of adult low back pain. The frequency of low back pain with adolescents increases over time, with prevalence rates reaching that of adults by the late teens. We know that 20 to 40% of U.S. adolescents with low back pain receive an opioid prescription from an MD. And a systematic review by the researchers for our current study discussion found that for conservative treatments for low back pain in children and adolescents, there were no published trials focused on spinal manipulative therapy, and only 3 small studies focused on exercise. But now we have a high-powered, randomized controlled trial just published in March of 2018 in Pain, entitled Spinal Manipulation and Exercise for Low Back Pain in Adolescents, a Randomized Trial. This was a multi-center randomized study with screening, intervention, and data collection at 2 clinical research centers in Minneapolis, Minnesota, and Portland, Oregon. This trial compared 12 weeks of spinal manipulative therapy combined with exercise therapy or exercise therapy alone. There were 185 adolescents with chronic low back pain with or without leg pain. Exclusion criteria included participants who have had spinal manipulative therapy, exercise therapy, or changes in prescription pain medications within the past month, or other concurrent provider-based treatment for low back pain, or if they had contraindications to care including spinal instability, inflammatory arthropathies, or benign joint hypermobility syndrome, or other serious physical or mental health conditions. The key strength of this study was they met the required 92 participants per group to ensure 92% power at an alpha level of 0.01. Some interesting demographics were that over 2/3 of participants were female. The duration of back pain was more than 1 year in 72% of the participants, and the mean severity pain rating was moderate. 11% had radiating pain to the leg. The intervention period was 12 weeks. Chiropractors and exercise therapists were trained to deliver the exercise therapy to both study groups. ET and SMT could have occurred in either order. In other words, ET either before or after SMT. Let's delve into the protocol for how the groups were managed differently. The exercise therapy program included self-care education, supervised exercise, and instructions for home exercise. Participants attended 8 to 16 45-minute sessions with an exercise therapist or licensed chiropractor no more than 2 times per week. Treatment dose was determined based on patients' abilities and needs. Self-care education included patient-centered goal setting and emphasis on the importance of movement and activity, pain management, and spinal posture awareness with basic activities of daily living. For exercise training, participants were also provided printed instructions and photos for each exercise along with a modified Back in Action book. Each supervised exercise session began with a 5-minute light aerobic warm-up followed by stretching and strengthening exercises, including a bridge, abdominal crunches, quadruped, side bridge, and back extension. Participants began with exercises appropriate for their fitness level and progressed in difficulty by changing body position and surface. In addition, they were provided instructions to perform the same exercises at home and to engage in 20 to 40 minutes of aerobic activity twice per week. For the SMT group, participants attended 8 to 16 10 to 20-minute visits with experienced licensed chiropractors no more than 2 times per week. SMT visits took place on the same day as ET sessions when possible and could take place either before or after the ET sessions. SMT dose, spinal levels treated, and technique were individualized to the patient based on the patient's prognosis, tolerance, and needs. High-velocity, low-amplitude SMT was the preferred technique. However, low-velocity, low-amplitude SMT, mobilization, flexion-traction manipulation, or drop-table-assisted SMT could also be used. Up to a few minutes of ice or heat or light soft tissue massage was allowed to facilitate the SMT if necessary. Compliance rates were extremely high, with 91% of study participants attending their prescribed treatment visit, 96% for the SMT plus ET group, and 87% in the ET alone group. The mean number of ET visits was around 10. And the mean number of SMT visits was 10 in the SMT plus ET group over 12 weeks. The outcome measures were standard, with the primary being an 11-point pain scale, and secondary outcomes included the Roland-Morris Disability Index, the Pediatric Quality of Life 23-item questionnaire, frequency of medication use, and patient satisfaction. Self-reported outcomes were collected at the first 2 baseline visits and at 4, 8, 12, 26, and 52 weeks. Well, now the results. Researchers found SMT plus ET to be, quote, significantly superior, unquote, to ET over the 1-year period, but not in the short-term profile. However, we need to look a little deeper at what supports this statement. It isn't quite as clear as a single statement. Recall that a measure of success in a study comparing 2 groups is first determined by statistical significance represented by a p-value, which translates into an acceptance that 5% of the time the results could be due to chance. Next, more of clinical relevance is the 95% confidence interval, illustrating the potential low and high point of a range of values that might be found if looking at all individuals. This also accepts that 5% of the time the resulting range could be due to chance. Based on the adjusted mean difference for reduction in pain severity on the 0 to 10 scale, there was an advantage of 0.5 for SMT plus ET over ET alone at the end of 12 weeks, 1.1 at week 26, and 0.8 at week 52. But now the question, is that difference clinically important, meaning does it represent a clinically important difference that patients would perceive as significantly different, regardless of whether it is statistically significant? Doubtful. Another way the researchers looked at the results was, on average, the difference in proportions for reduction of low back pain severity across all possible thresholds for improvement favored SMT plus ET by approximately 7% at 12 weeks, 17% at 26 weeks, and 10% at 52 weeks. Sounds more impressive, but what does that mean, the expression as proportions and percentages? When you're searching for a positive statement in a study where there are no obvious differences, you can keep averaging effects and use this as a percentage. Is this accurate and true? Yes, but it is a distortion of the actual study findings, leading the reader to likely overestimate the effect size. For example, at 12 weeks, there were no differences between SMT plus ET and ET alone for minimal or moderate reductions in low back pain severity, but a larger proportion of participants in the SMT plus ET group experienced substantial reductions in pain severity at 75% to 100%. But again, this is the proportion of participants, not the actual mean differences. By week 26, an advantage was noted for SMT plus ET across all levels of reduction in low back pain severity, ranging from 14 to 25% greater proportions of participants. This clearly is significant. At week 52, approximately 10% more participants from the SMT plus ET group reported minimal or moderate reductions in low back pain severity, but these findings were not statistically significant. Let's get another perspective. Here we see only 2 p-values reaching the 0.05 p-value threshold for statistical significance for pain reduction. And note only 1 p-value reaches the required 0.05 p-value threshold for the Roland-Morris Disability Measure. This is at 6 months. Now to the 95% confidence intervals. For the percentage of pain reduction at week 26, there are obvious meaningful differences, especially for the 75% to 100% group. And for week 52, we see that for all, the bottom level of the confidence interval is negative, indicating that the range includes favoring the ET group over the SMT plus ET group, nullifying a difference between the groups. And significant are the findings of secondary measure analysis, where the quality of life and medication use did not significantly differ over the 1-year period. The researcher's conclusion states, quote, "For adolescents with chronic low back pain, spinal manipulation combined with exercise was more effective than exercise alone over a 1-year period, with the largest differences occurring at 6 months. These findings warrant replication and evaluation of cost effectiveness," unquote. Let's rephrase based on the observations regarding p-values and 95% confidence intervals. The only significant differences that were both statistically and clinically significant was for the SMT plus ET group at 26 weeks or 6 months. This seems lost at 1 year. This was a high-powered study which, in essence, demonstrated a significant effect only at one time point at 6 months. Limitations could be that because the researchers chose to make this a more realistic study with provider choice of type of SMT and adjunctive care, it may not represent the findings of a more controlled study. As the researchers state, more studies are needed.